Welcome to everyone. You're here for the CAPT webinar, a critical look at intergenerational trauma and substance misuse, looking at implications for prevention. I'm thrilled to be joined today by Karina Forrest Perkins. I will introduce her a little bit more in just a moment. I'm Gisela Rotz. I'm the team lead for the Northeast Resource Team of the CAPT. So today we'll be starting by talking about trauma and honing in on intergenerational trauma and how that impacts both individuals and implications it might have for our wider environments. We'll then explore the connection between intergenerational trauma and substance misuse. And then we'll kind of finish up by using a case study. We'll identify some trauma-informed prevention approaches across a few of the socio-ecological levels. Our objectives, again, we'll define and identify how intergenerational trauma evolves, so focusing in on the evolving component, making that connection between intergenerational trauma and substance misuse prevention, and again, those trauma-informed approaches. Without further ado, I want to introduce Karina Forrest Perkins. She's a CAPT associate. I'm absolutely thrilled to be joined by her today. Karina is a national speaker and technical consultant on culturally responsive systems improvement related to early childhood and adolescent neurodevelopment, the adaptive impact of overwhelming stress, and the intersection of that stress with substance use and misuse. She also serves as the Chief Executive Officer for Wayside Recovery Center, or the Wayside House, which is a women's chemical dependency and co-occurring treatment center. And Karina has worked both in prevention and treatment, and so she's really valuable insights in helping us to identify how we can address this topic. So again, I'm going to put her on the spot and encourage you to ask some of those hard questions. Karina, do you want to say hello?
Hello, welcome to everybody. It's an honor to be here. Very exciting to be able to have a conversation about trauma-informed content and approaches and strategies, and prevention is one of the most exciting things for me to see prevention talking about this issue, and I can't wait to see all of your questions and hear your feedback. Okay, so let's start by defining a few of these terms and thinking about, as the presentation goes along, be thinking about what is happening as we're describing this phenomena and how we can show up differently in our prevention work and partner differently. Because I think that it's going to be very revealing what we're dealing with in our society today and how we need to look at things just a little bit with a different lens. So let's start by, as Gisela said, let's start by looking at some of these terms. So what is intergenerational trauma to start with? It includes trauma and adaptive characteristics to that trauma, which took place in a previous generation and are now manifesting similar adaptations in the present day. And as you see in that definition, we say, when I said it includes trauma, in parentheses it says accumulation of stress, because some of the individuals that you will talk with and populations that you may come in contact with do not refer to their experience through the lens of trauma, but they will be able to talk about it through the lens of stress or being overwhelmed or an accumulation of things that were risky or dangerous, okay? And it's important to note that when we talk about these adaptive characteristics to that trauma that took place, that we understand that these adaptive characteristics are normal. They are normal and understandable responses to stress. So giving an example of characteristics that may be present with intergenerational trauma, that could be exhibited in our behaviors, our language, our culture, norms. There's also a new body of knowledge and scientific research on genetics, and that the amount of stress we accumulate, depending on how overwhelming it is or consistent it is, or across generations, it can actually have an impact on our predisposition to physical illness, mental health problems, substance abuse, or dependence. So it actually can impact our genetic expression generation after generation. And for the purpose of this presentation and seeing this through the lens of prevention, we want to think about intergenerational trauma as the transmission of risk and that movement of trauma adaptation from the current generation to a future generation. And so it's not just the transmission of high-risk behaviors, but it's the transmission of behavioral adaptations that have occurred as a result of being in high-risk circumstances that follow you generation after generation after generation. And as many of you already know, prevention-targeted populations are often impacted by this accumulation of high stress. And when we think about what some of those environmental stressors might be, we think of generational poverty, racism, substance abuse or drug trafficking, sex trafficking, lack of access to health care, lack of access to transportation, a lack of opportunity for educational advancement or vocational advancement. So this really has a lot of depth to it. And what we'll do, we'll move forward a bit and talk about some of the other terms that are spoken about in tandem with intergenerational trauma, and then we'll loop back on this again. So let's go then to these topics. So these terms. So you'll hear the term overwhelming stress, and this is probably the one that I use the most, mainly because a lot of the individuals that I work with, whether they're a client receiving an intervention or a community trying to understand their role in prevention, they don't typically use the word trauma as often as we might think. So when we talk about overwhelming stress, this is a physiological phenomena that's occurring. So stress has many forms. Our bodies can handle a myriad of stressors from the environment. But what happens is our body is really only able to hold our stress hormone of cortisol for about 23 minutes at a time. And we were designed that way, that if we become alerted, if we are in danger, if there is a perception of threat, that you do have a physiological response that protects you when this occurs. But if this begins to happen on a consistent basis over a longer period of time, then that causes a toxic response to the system. And you will begin to see adaptations in our behavior or in our development as a result. And then the term trauma is typically referred to as a psychologically distressing event outside the range of usual human experience. Again, we don't determine what is traumatic for someone else. They determine that. We can, however, learn someone's history and how it includes an accumulation of stressors. Now, whether they believe it was traumatic or not is not necessarily as relevant, but it is a term we need to be familiar with. So then looking at developmental trauma. Developmental trauma is an accumulation of overwhelming stress during sensitive periods of human development. This could be from conception to 3, this could be 6 to 9 years of age, it could be 13 to 17 years of age, 17 to 27. It takes the prefrontal cortex to the age of 27 to fully map. We have multiple sensitive periods of human development. So developmental trauma is when you're experiencing high accumulation of stressors during those sensitive periods. And then historical trauma is the transmission of risk that originated generations ago and caused epigenetic changes. That's changes to an individual's biology and genetic makeup that leads to further genetic risk in future generations. And typically historical trauma is used to discuss things related to very large societal events like genocidal behaviors, relocation behaviors, things like enslavement practices, the Holocaust. So sometimes you'll hear historical trauma and intergenerational trauma used interchangeably. They're not always referred to the same. So just to know the differentiation between those two. And then the stress versus trauma. Now, we talked about that on the previous slide. Again, just to reiterate, everyone experiences stress. In fact, we have to, or we don't learn anything, we don't experience anything new, we don't build new skills. Stress is very important to our body, our our survival for the species and for our relationship functioning. But the accumulation of large quantities of stress over time changes that experience on our body and how we are in the world. So what happens when our bodies and brains are introduced to that overwhelming stress? We talked about it in terms of the word adaptation. It's not brain damage, it's not maladaptive, it is adaptive. We create skills that help us to be in the world in the way that the brain and body perceive we need to be in the world. And so due to a consistent level of stimulus in our stress response system, specifically our neuropathway connections, our chemical composition with adrenaline in the body and the muscular system, and cortisol, our stress hormone in the brain tissue, that all impacts what parts of the brain are able to function and when and what for and why. And then that impacts our skill building that prepares us for the environment that we're in. And that shapes and conditions us, not emotionally and cognitively only, but physiologically. And that physiology manifests in our thoughts and language, our connection to other people, our ability or inability to self-soothe, to engage relationally, and either we actually may have a heightened response to a stimulus or an inhibited response to a stimulus. Basically, it shapes how we are in the world. And one of the most important pieces of this from the prevention lens is it has a significant impact on our ability to attach and bond with other human beings, and then to value and regard well society and environment where other human beings are present. Okay, so in the slide you'll see neurons to neighborhoods is mentioned, and that is an article actually that came from Harvard Center on the Developing Child, Dr. Jack Shomkoff, that was published in 2001, and he actually really outlined for the first time the impact of overwhelming and high accumulation of stress, and his term was toxic stress, on early childhood development. And before that, in the late 90s, the adverse childhood experiences surveys had taken place, 1995 and 97. And they teach us a lot about individuals, families, and communities in the United States. And what the adverse childhood experiences study actually told us was, or taught us, was that there's far more risk and stress transmitted from previous generations than we had believed previously. And that this transmission adversely affects our health and our social outcomes. So the original ACE study, and then all of the different surveys that have utilized the ACE survey questions since the 90s, have shown that between 54 and 68% of the general population have experienced high stress accumulation, either in the present or through generational transmission. So let's go to this next slide. And this is just a simple pyramid to show you a progression. You have this foundation, right, of stress, and it accumulates over time. And if it accumulates in a way that it exceeds our body's ability to process it, then it becomes overwhelming and toxic in effect. And that causes adaptations in our behavior. And those adaptations feed into risk factors that keep us in high-risk circumstances. They also feed into genetic and parenting practices, so genetic predispositions to risk and parenting practices and family norms and community norms and neighborhood norms and ideas about the world we're in. And that shifts into a more historical, developmental, and intergenerational process that goes from generation to generation, carrying these risk factors with us. And from that prevention mindset, we're really looking at the risk and protective factors on a regular basis. Those are our a significant guideline for us. And if we better understand the depth of the risk factors that we are trying to shift and change, the history behind them, how they evolved, what happened, and we really understand that narrative, then we will better understand those strategies in prevention that will be relevant to individuals, families, communities, and the greater society, and then we will meet our goals in a much more effective way. And just to kind of reintroduce it again, I'm just going to be saying this pretty consistently throughout, is that if you have had to defend yourself against your environment for a significant percentage of your life, and you have, as a result, had adaptations that have occurred where most of your skills are built in defense and survival. They are not built then on engagement and attachment and bonding. What we then see is we start to have a world view that is shaped in our way of thinking and how we connect with the environment that we're in. And that world view begins to question things like, are we a valuable part of this world? Are we a valuable part of our community, of our family, of our society? Or do we have to survive the world and defend ourselves against it all of the time? And at a basic level, our body is actually prepared to defend and be on guard and avoid attachment to stay safe. We're not as much building skills around trust and relationship and attachment and bonding. So I just want to kind of reinforce that this is a physiological phenomena that we are experiencing. This is not as much a matter of choice, right? This is not cognitive choice that we pull from our brain function, our executive functions of the brain in our cortical region. We talk about our frontal lobe, our most advanced human thinking. Many of those skills don't have an opportunity to develop in a safe environment because we're focusing constantly on defense and survival. And so those executive functioning skills are not as accessible to us as a result. So let's just take this away from the human idea, from the human example for a moment, and let's use gardening. So if I were going to ask you, I'm sure many of you are familiar with gardening. I'm sure many of you are familiar with planting hostas, right? And what that involves and what hostas need in order to thrive. So if I were going to take a hosta, buy it at a nursery and bring it home and plant it in my yard, right? And I'm getting ready to plant this in my yard, and I decide I'm going to plant this right in the front yard in full sun, and I'm not going to water it, all right? And so immediately, those of you who have gardened and who have planted hostas, you're going to say, oh my gosh, you can't plant hostas in full sun unless it's a special strain, and you have to water it, right? Because if you don't, then it's going to start looking like that picture here on the slide. It's going to start to pull all of its resources to the roots in order to survive. And so the life, the things we see in the hosta, the things that the hosta has exposed to the world are going to start to pull resources back from that. Right? It's going to start to, you're going to see the energy and the life of the hosta pull internally down into the survival part of the hosta so that it can live. Now, I'm not going to go out there as a gardener and say, oh my gosh, you absolutely difficult, obnoxious hosta, right? No, I'm not going to blame the hosta because the hosta is not doing well in an environment where it was never meant to thrive. If I know about gardening, if I know about hostas, I will know that I have to move the hosta to an environment in which it thrives. That had I read about those or known about those or had simple education about those, I would have done that in the first place. Then the hosta wouldn't have had to survive, right? It would have been able to thrive. And it would have had both the ability to use its own skills to survive as well as environmental support in order to thrive. So going to understanding brain function, I just want to, and again, I'm just stressing this physiological component around what happens to us when we're stressed. So the brain is so complex. And in this webinar or in a college course, it would be difficult to explain everything to you as far as what the brain actually does and how it impacts our behavior. So for the purpose of this presentation, we're just going to look at 3 regions of the brain, right? Our basic functioning of the brain around survival, which is our most automatic functioning, our threat response. It is the first part that develops, so it's the oldest, has the strongest neuropathways. It's really going to be the part of our brain that is going to always be in control at the end of the day, okay? Because it's more important that we're alive than the other 2 parts are working, right? So then the midbrain region is our emotional control, and it's our chemical command center, and it has to do with our sensory functions and our sleep alert system, our temperature control. It's what helps us sense our experiences. And then our cortical region is the intellectual function, the judgment, the planning, the course correction. And they're essentially intended, these 3 regions, to, number 1, keep us safe and alive so we have experiences. Number 2, to feel and sense our experiences. And 3, to think about and make meaning of and plan for future experiences. When our stress response system is consistently activated because of our perception of danger, then we build our skills more robustly in the survival part of the brain than in the midbrain and in the cortical region. And so if you think about this in terms of a child, if a child has grown up in significant stress environment and then begins to have a difficult time self-soothing or calming down, and then goes into a school environment and is expected to sit there and take in information every minute of every day, the child doesn't have skills to do that. And so the child will many times look for ways to self-soothe so they don't get disapproval in that social environment. And that seeking for ways to medicate that stress is many times where we see the problems of substance misuse begin. So the more prepared we are for danger, the less our brain perceives important relational information, right? What we need, what we value, what we want to be able to engage in, those things don't have the same weight in our thinking because we're having to survive. So we don't have the leisure to be able to spend time there. And then when we talk about intergenerational trauma are generation after generation of growing up in an environment where the norms, the culture, the learning that takes place is surrounding the idea of survival and defense and protection. So for example, growing up in a community where drug use is transparent, where it's prevalent, and this becomes normal, witnessing consistent substance misuse in the home, growing up with community violence, growing up with your basic needs not met, your food, your utilities, your shelter compromised. Those things shape the way you think and value yourself and the world as time goes on. So I think at this point, we're ready to go back to you, Gisela.
Great. Thanks, Karina, and thanks for walking us through all of that. And I think it might be helpful right now to just kind of do a little bit of reflection. So what impacts do folks sense that intergenerational trauma can have on a community? Brian talks about the challenges to the education system. Absolutely. That's one of the first things that comes to mind, right? As people kind of become more inner focused, it's much harder to engage in that education system. Community disorganization, lack of social connectedness, which links back to Karina, what you were talking about around the attachment and bonding and engagement. Robert's point around folks not even knowing perhaps that they've been traumatized.
That was a great point, great point.
And so Karina, do you want to say a little bit about how that might manifest itself?
Right. A lot of times what you'll see, individuals who have experienced a significant amount of stress and have created adaptive behaviors to cope with that, you may see that show up in being more prone to create drama in an environment where there's not any, merely because that's where their skills are most effective, right? They know how to cope in that environment better than they know how to cope when things are going well. So they may actually create some drama or some chaos so that their functioning can be turned on. You may see some victim type thinking, a lot of blame. You may see that they feel they have a low sense of value to the world around them. They don't value the laws that are around them. They don't value the rules in an environment that they're in. They don't value, again, if they've had to survive their environment, they don't necessarily value the things that come from it. You also may see some things that are just physical in nature. So hyper alert, difficult times self-soothing, so hard to calm down, trust issues, blame, lack of self-determination. And trust is important. Why should they trust, right? That wouldn't even be wise for them to trust. There's so many.
There's a lot here, and it also strikes me, you know, Kimberly talked about distrust of providers, right? And that can be, if you don't understand kind of what's happening with a person and why they're responding the way they are, for providers, that can be very frustrating when people don't seem to want their help. We have to keep that in mind as, you know, in substance misuse prevention, about what does that mean about how do we engage. And I think that one of the things that we look at in our work is like, okay, so how does all of this fit together? And what we see is, and this will not be a surprise to any of you, but the interlay for how we can address intergenerational trauma and prevention and kind of look through those lenses is through the role of those risk and protective factors, right? The connection that's been made around ACEs that Karina mentioned earlier, the adverse childhood experiences. We see a really strong relationship between those adverse childhood experiences, some of those other trauma-related factors, and the substance misuse risk factors, and what might be happening in the home. But it does mean that we have to respond a little bit differently, and that's kind of, right, like we'll be moving into a longer conversation about that piece, bringing that trauma-informed lens conversation up next. Karina, I'd like to hand it back over to you.
Sure, absolutely. So when we talk about bringing a trauma-informed lens to prevention, this is a new idea. Typically, when we talked about prevention back, when I started in the prevention field in the 1980s, we started talking about primary and secondary and tertiary prevention and the risk and protective factor research by Hawkins and Catalano, and there was so much separation between the idea of prevention and working with individuals who had already sustained risk. Now we're understanding our society differently, our data differently, and we're beginning to understand that it's going to be very difficult to work without connecting the two, because our population has a much higher prevalence of stress and trauma than we previously understood. And when that is the case, and we begin to look at how to structure prevention strategies with our populations, we have to consider that in terms of everyone that we work with, right? It's not just an individual in a classroom. It's not just a child in a classroom that we happen to know their history. It's the teachers in the school system. It's the administrators. It's the law enforcement officers. It's the people in our community that are parts of our prevention coalitions. 50% or more on average throughout the United States are going to be in a category that has experienced an accumulation of high stress. This is not just a population kind of over there, that idea that this group over here has experienced it and the rest of the community has not. We now understand this as a more universally applicable issue. So it really has an enormous amount of weight and bearing to how we interact in all of our prevention partnerships, our contracts with our statewide entities, our relationships across coalition activities, et cetera. So if we look at the different levels, right, the approaches, the individual, the relationship between individuals, the community, the societal level, and we look at it with that new perception, that new understanding of reality, that risk is present in a way that we didn't understand it was present before. What does that then mean for us when we actually explore the strategies on prevention? How does it impact the way we are in the field, and how do we promote? So for example, let's take the risk and protective factors and look at the protective factors and the things that we would be promoting as positive norms or as environmental changes that would be shifting norms in a positive direction. If 50% or more of the population in that community have experienced an accumulation of high-risk circumstances, then their perception and ability to kind of mentally digest or metabolize the promotion of these new ideas and these positive practices is not going to resonate with them as well as we had once thought that it would. So again, it's just a reframe of understanding our society differently, understanding how people show up in the world and what that worldview is and what that looks like. So then looking at the next slide, and we start to talk about trauma-informed approaches, and Gazelle is going to open up a case study here in a minute, and we're going to kind of dissect and unpack that a bit. But when we talk about trauma-informed approaches within the prevention context, we're talking about some really basic now relational ideas that must undergird a successful prevention strategy. Because prevention works with human beings in the context of community, because it looks at the changing of norms, the changing of the environmental culture, the shaping of culture over time, so it no longer tolerates what it used to tolerate. All of that is so predicated on relationship and communication and connection and understanding. And if those things are not as present for 50% or more of the population you're working with, then you're going to come up against some pretty strong reactions or some pushback that maybe you didn't anticipate. And then you have to back up a bit and begin to look at how to build basic ideas of relational connection when you're looking at your strategies. How do you build trust? What do you include in your strategy that incorporates trust building? How do you create a safe environment? What does that even mean? Is it physical safety? Is it emotional safety? Is it moral safety? What does safety mean, and how do we know what that even looks like, right? Then support. How do we provide support to individuals where they have informed what that means? Where the individuals who are affected have actually taught us what it means to have meaningful support. So often in models of culture shifting and change management, we don't ask the people affected to actually inform the direction that the model goes. And this entire context requires that we do that, so that we have that is going to be fundamental in building safety and trust and coming up with meaningful strategies that are actually going to move the needle. So, Gazelle, I'm going to turn it back to you to open the case.
All right, that sounds great. Thanks, Karina, and thanks for making that connection and making it so clearly. I hope that was helpful to folks. We thought it might be helpful, though, to kind of think about how would we take this information and apply it in a setting. So what we're going to do now is we've pulled together a case example, and then we'll look at a few of the socio-ecological levels and how we might respond in a trauma-informed way at each of those levels so that we can get very concrete. Whether you're at a state level or a community level, kind of came up with an anecdote that we think might resonate. So is a parent from a local family is being treated for an opioid use disorder. And since the parent entered treatment, the youngest child has been acting out in school and quit the sports team, right? So basically, so we know kind of from what Karina has talked about that this child has been not just experiencing overwhelming stress, but probably has experienced trauma as well. And we should say we don't know what's been happening in that family over generations to kind of lead to this particular point. So if we kind of look at this child and we think about at the individual level, what would a trauma-informed approach look like? The types of interventions that we could be thinking about using to help support this particular child, right? And we'll move out a little bit further in the levels in just a moment. But on the kind of individual level, right, kind of creating interventions that support safe spaces for the youth, teen groups, so that the child can kind of continue to build trust and encourage positive behaviors amongst the child and their peers, right? So supporting after-school programs, but also going to provide or support counseling or other social services for that particular child, right? So some kind of counseling that includes a motivational interviewing component. Karina, is there something that you would add to this about, how you might think about responding for this kind of a child?
This is something that, unfortunately, in our society, we're seeing examples like this occur on a regular basis. And many times with substance misuse, the child may have experienced more than abuse or trauma in terms of abuse. They may have experienced neglect. And so, again, a lot of mistrust that adults can meet their needs or can assist in providing safe and healthy support. So then how do you fill that? How do you address that? And obviously, if you're looking at the treatment side of that, there's several examples of what you would do if the child manifested a need that would justify that. But on the prevention side, you could have, it mentions the child has been acting out in school. And I would wonder what you could do in terms of providing a different learning option for that child where, as you mentioned, supporting after-school programs, maybe quiet time, maybe another classroom where there were not as many students present. Maybe there's an opportunity to work more one-on-one time with a tutor or to reestablish trust with an adult in a safe and healthy way. The scenario mentions quitting the sports team. There could be individuals in leadership on the sports team that could make home visits, that could encourage the young person to be involved in different ways until such time as they would like to rejoin that particular sport or a different activity at school, finding a way to keep engagement alive as opposed to it getting thinner and thinner and thinner as the child begins to detach and you begin to see attachment getting eroded.
That's super helpful. Yeah, so really kind of helping to kind of create those attachment opportunities, those bonding opportunities. But I think this is a good time to move on to the relationship level, right? So because you talk about, kind of how do you kind of keep those strong bonds going and helping to support those. So an intervention on the relationship level might focus on supporting that strong bond within the family. The example we've used here is the positive parenting program, also known as Triple P, which really kind of provides an opportunity for that child to connect with their parents. Karina mentioned the schools, and so kind of thinking about how can we help teachers or those coaches understand how they can work and interact with the youth who've experienced this trauma and kind of are maybe beginning to not, I don't want to say shut down, but really beginning to kind of struggle with their attachment. And the idea of collaborative problem-solving training, which is, it's a program where teachers and other adults work with a student to address what we might call quote-unquote behavioral concerns. It's not focused on punishment, but rather kind of that communication and thinking about how together they can address some of what's going on for the child in the child's life. And I think that these kinds of approaches really provide this context of, like, we're not going to be indifferent to what's happening. Anything you would add to that, Karina?
Sure. Yeah. I mean, I love these examples. I think they're both outstanding. I think one of the things that we tend to do is we make assumptions about what might be going on when a child is beginning to detach or not be present. So if the child is no longer present on the sports team and we see a lack of attachment, it might be helpful to ask what is happening in the child's life. What if they're staying home to watch their siblings, right? Because their parent is in treatment or their parent is getting support, and so who is taking care of things around the home that the child may feel like they need to be there. So again, it's understanding what's happening in these relationships that might impact participation in the broader society in the way that they used to show up in the broader society. A great example that took place in the relational level in Duluth in Minnesota, there were some practices that went on in the high school that were pretty punitive when kids were truant from school, or they just were not engaging, or they were breaking rules, or something that was not going particularly well in terms of the relationship between the student and the school. And they were written these tickets by the police that were actually staffed in the hallways in the school. And so the students got a real bad taste in their mouth about the police and the relationship with the police and the relationship with the school for bringing in the police. And so the school ended that practice. But one of the things that they did that I thought was absolutely fabulous is they brought in, and they waited a period of time because it was important that they did that to give some separation between one set of behaviors and another set of behaviors. But they brought in mounted police. Now, you can do that in Minnesota. But they took the Canada example, and they had police riding in mounted on a horse to the school, just hanging around, not writing tickets to anybody, but just hanging around. And it really drew the kids to the officers. They were able to connect over the horse and what they were doing, and the kids got to take rides, and it was fabulous in terms of building relationship in a safe and trusting way back with the police after you had some difficulty that had occurred in the community. So it's really a good example of something I thought was creative and coalition driven.
That's an incredible example. We're quickly going to go to the community level and talk about the kinds of interventions that might be relevant at the community level. And here, I think, based on what we've seen in the chat so far, I think that these will resonate with you all, right? So thinking, again, about what it means for a child or a family to be experiencing that trauma, and I want to call it the tenderness of that attachment, right? Like, it can be tender in that it can be vulnerable, but it can also be tender in that it can be incredibly caring. So including those trusted community champions who understand that and understand that tenderness, if you will, for the attachment component in the decision making and in the implementation of community-based programs, again, to help make sure that we're engaging people who are trusted across the community. ensuring that there is community engagement when we're thinking about how do we change community norms to take a more maybe trauma-informed approach, as well as establishing spaces where these community sectors can come together and collaborate. And we'll talk a little bit more about those opportunities for collaboration. And Karina, anything you would add here?
You know, I love this. The idea of including the community's voice to design strategies, not just based on their readiness to change, but their established wisdom in the community. A lot of times when we think of intergenerational trauma, we think of things that contribute to crime and poverty and violence and illness and behavioral health issues and transients. But it's really important that these individuals, when they're in environments that have poverty and violence and illness and behavioral health problems, and that they have skills to endure that and thrive in that environment. And they can really, so for example, one of the examples I heard from Washington State that was fabulous, they were the Family Policy Council. If you Google the Family Policy Council in Washington State, they have this massive prevention initiative that they no longer sponsor, but there's so much information on that website. And they had an example in a community where there was one home that was not able to pay their utility bills. So the coalition effort talked about options were, I need to go get some services. There's this community action partnership I can go to get services to get my utility bills paid. But to do that, I have to get transportation to that building, and I have to get there, and that means I have to take off work. And if I take off work one more time, and so there was all this risk. And basically what they did is they took an extension cord from the neighbor's house, and they ran it across to her home, and they let her use it to plug in the things she needed to get her children ready for school in the morning. So they had a hair dryer going on it, then they had a curling iron going on it, and some of the coalition members thought that was ridiculous. And the community said, no, this is what I needed to get me to where I could get energy assistance, is I needed the community, the neighborhood to come together to provide some assistance. And what looked a little survivalistic and odd to some of the coalition members in that greater community really came from the wisdom of that community on how to cope in that situation until more stable resources could be found.
That's great, and what an interesting example. And so you said it was the Family Policy Council, right?
Family Policy Council, yes, and there's so many examples of where they came together to provide child care cooperatives in the neighborhood. Very non-conventional, so very not a traditional programmatic response to some of the stress that the community experienced as a result of historical stress. It was great. Some of their examples are phenomenal.
Wonderful. Excellent. Well, thank you for those examples. I'm actually going to jump back to a question that we got in the chat box, Karina, which was Iris and Robert were commenting that it is probably really important to think about ruling out medical or cognitive things that might be coming up as a result of that treatment, and just kind of keeping that in mind. And I wonder if you have any specific thoughts on that as folks are filling out our...
Yeah, I loved those comments, and I really think that, again, that's really a critical reason for why prevention and treatment fields benefit from working closer together, because if something like this occurs in a community where you have a coalition effort and you think there may be something there that might be occurring, or you just want to be safe and have a behavioral health practitioner provide support, by having that close and symbiotic relationship with intervention folks, with treatment folks, they can provide you that resource. And you're not involved in that, right? That's not your field. So you're actually having a nice, warm, safe handoff to another resource right there in the community that can provide those resources to eliminate those possibilities from getting in the way to a successful outcome.
That's helpful. Thank you. And the other topic that had come up was a question about the role of mentoring. And I imagine that if it's a strong and well-established mentoring program, that could be really helpful, but we'd probably have to be pretty careful to make sure that there's a commitment there, right? Like I'm thinking about if a mentoring program is not going to continue, this idea of like, that could do harm to a child's ability to build attachment because it could be an attachment that gets broken again. Is that
right? And that's a very good point. Mentoring is highly, it has very positive outcomes associated with it, and when funding is cut and those programs go away, it can be devastating. So just to know that, and especially if you're working in non-white communities, if you're working in communities of color and you have a mentoring relationship set up or a program that supports individuals of color, to understand that just the historical context of attachment and trust and separation and suspicion around people's agendas makes all of that even more really relevant on not letting that mentoring relationship get disrupted.
So really taking that idea of nothing about us without us to heart when we're talking about these populations.
Right.
Really important. Excellent. I want to jump over to the societal level. We hadn't had a chance to talk about that. And so we've got some folks talking about advocacy, right? Advocacy in the sense that we need to educate people around what it means to be trauma-informed, as well as thinking about infrastructure, sharing resources, and scans of policies. Karina, you and I have talked about the idea of community resilience, and I wonder whether we should talk about that here for a couple of minutes. We've talked about resilience, or it's come up a little bit earlier, and it's a term that we can sometimes struggle with, right? But I wonder whether you'd be willing to say a few things here around, at the societal level, like what does community resilience mean, and how do we build that as a part of a trauma-informed approach?
Yeah, it is such a difficult topic to navigate. When we talk about resilience and having resilience building strategies, most of the time it's on building resilience for the individual. And what that ends up doing is that ends up being kind of the inverse of that bootstraps argument, right? Where it's all of the pressure is on this individual to be more resilient so that they can handle more adversity. That's not said in an overt way, but it is certainly a message that a lot of people take away when they hear about being more resilient. And they feel that pressure. It's all up to them. It's up to them to cope. It's up to them to survive. It's up to them to be socially functional. It's up to them to have high levels of executive function, even though they didn't have an opportunity to build those skills. So it's really difficult. And when we talk about this shift to a joint accountability for change between individual resilience and community resilience, we're talking about kind of back to that HOSTA example of what do children and families and communities need in order to thrive? What do they need in order to foster connection? What needs to be in place so that the environment, so that the community can actually build those things? So if you have families that have problems with drug misuse, which is a chronic health condition like diabetes, and if you have a chronic health condition in the community, what can the community do to be more supportive to parents or adults getting treatment and supporting those children while their parents are getting treatment? What can we do in the community to be able to have a welcoming environment for families coming out of treatment and beginning to learn how to heal and thrive together in that community, instead of experience a lot of the norms around stigma that we do, right, that push us back into that individual resilience box. So that community resilience can really look different community to community, and I would tend to ask the community, what do you believe families need in your community in order to thrive? What do you believe needs to change? What do you believe needs to stay the same? And they will give you the key insights you need in order to build a plan on how to tackle that problem. They have that wisdom. And having them really at the table, someone made the comment that if you're not at the table, you're typically on the menu. And I think that's just a great, it really is impactful when you're a community member. You feel like if you're not a part of the decision making about what you need to do to contribute to the resilience in your community and the accountability supporting individuals who intersect with risk, or you're trying to interrupt the transmission of risk from one generation to the next, how are you going to do that if people don't ask you what your opinion is and how to do it based on the capacity you have? So I think that's just a really big place to start.
That was really, really helpful. Thank you so much for that, Karina. And so kind of with that, I'm going to move us full steam ahead, noticing we only have a few minutes left, and we want to make sure we kind of loop back to a couple of other things. So we want to just pause for a couple moments before we finish wrapping up and kind of take again a step back like we just did with the concept of resiliency and community resiliency, and think more broadly about what implications does this have for our work in prevention, and specifically what does this mean for collaboration. And so I early on, Karina, when I introduced you, I mentioned that you have worked in prevention, you have worked in treatment, and I wonder whether you would be willing to just talk a little bit about what you see as, with the trauma-informed approach, what opportunities does that bring us for collaboration? Karina, your thoughts?
Sure. I think I started in the field in substance abuse prevention. So I have always had that prevention frame as my default position, and then have been in the treatment field for about 17 years after that. So now looking at, so for example, I'm working with women who are coming into residential treatment for substance misuse. Many of them are pregnant and parenting, and we're trying to interrupt that transmission of risk from the substance misuse of the parent to the children and that family environment. And part of what we're doing is working with prevention coalitions and initiatives across the state where these women live when they leave us, right, for this treatment experience, and they go into their recovery experience, is to look at how you can have intervention for mom and primary prevention for that child that's in the womb and who's getting ready to come into this environment, and what does that look like? So we're talking about ways where we actually serve on coalitions together. We serve on advisory councils together. We have preventionists in child abuse prevention, domestic violence prevention, sex trafficking prevention, obviously substance abuse prevention and mental health promotion. So we have those folks at the table with treatment folks who are providing treatment and interventions that are maybe deep end and high risk all across the state, and that helps us work. They know then where some of the issues are, where they can provide more supportive environments, welcoming people back to the community to provide support. So I think the first step on collaboration is to be present with one another and really understand what the scope of your partner's work is and how your work can intersect, where those intersections are. And that starts with spending intentional time together. I think those relationships don't occur as organically. It's almost an intentional, we have to plan intentionally to bring this multidisciplinary group together. But once you do that, it is a rich experience, and you'll find so many intersections. There's so much potential there to write grants together, engage in contracts together, work on community and environmental education, community education events together, having conferences that are held in tandem with one another versus separate. Just really try to erase that silo.
Thank you so much for that, Karina. And we're getting towards the end of our time today, so I'm going to move us along. Take a step back and recap today, right? So we talked about intergenerational trauma and that it differs from typical stress in that it produces actual changes to an individual's biology and genetic makeup, which means that we have to respond differently and appropriately. We've talked about the importance of attachment and building those bonds and finding ways to reinforce those with the appropriate people and who are also trained appropriately, right? So there's not just with anyone, but really being intentional about it. And making sure that we're using approaches that are rooted, again, in safety and trust, and thinking about how that can support prevention strategies in a community. That very important piece around making sure that we are engaging the population in this with us, and that has to be our guide, and that building of that safety and trust. I'm going to continue whipping through some slides here. We kind of went a little bit differently with today's webinar than we often do, but we really appreciate your engagement and kind of the conversation that you brought to the table so that we could have this discussion. It feels really relevant. It isn't a new topic, but we are thinking about it in many contexts, and it's very important. And I think that the questions that you have all posed clearly indicates that people have been thinking about this for a bit. All right. Karina, any last comments that you would make? We've got a couple minutes left.
Just to know that this is new, this idea is new, braiding trauma-informed care with prevention and looking at this differently, that is, there's not the same depth of research around it. That's still emerging, and to be patient and to be willing to experiment and try and share that learning that you generate with each other. So yeah, just to stay encouraged, hopeful, and connected.
Thank you so much, Karina. Really appreciate those parting words. And thank you, everyone. We really appreciate your participation again today and your engagement. And we hope you have a wonderful afternoon. Thank you.